this MKP1 alpha, an enzyme which goes to the cytoplasm, which goes through the nucleus into the cytoplasm and deactivates that enzyme which phosphorylates GATA3. And this is a prolonged effect because it synthesizes another protein. So this is prolonged effect. So we can safely say from these slides this. So corticosteroids inhibits GATA3 and the Th2 cytokine expression, and it has got rapid onset because this coming down into the nucleus is very rapid and inhibiting the GATA3 is very rapid, but it has got a prolonged effect because it continues to inhibit the GATA3 because it inhibits the phosphorylation of GATA3, and it is a very potent effect. So whenever we treat an allergic disease, this is what we are doing. Now, I haven't shown you these slides, so you have to trust me on this. There are studies, an Australian study and there is another study showing that formoterol actually inhibits the neutrophils as well. And do not, we always think that the asthma exacerbation is always eosinophilic. It's not so, not anymore. Because about between 20 and 40% of patients who have asthma exacerbation, you can check their asthma epithelium and you will be surprised to see that it is a neutrophilic inflammation between 20 and 40%. And on those patients, steroids don't work as well as they do when there's an eosinophilic inflammation. But formoterol does. So, and it bronchodilates and it inhibits the mast cells. When you give budesonide or any steroid for that matter, it does the same thing, inhibits the mast cells, it inhibits the epithelial cytokine to recruit more eosinophils, and it inhibits the Th2 cells. So, in conclusion, what we can say, the interaction between the corticosteroids and beta-2 agonists, the corticosteroid comes in, and as we have shown, that it inhibits few things. However, it activates another gene, which is the beta-2 receptor gene. And the moment the beta-2 receptor gene is activated, the number of beta-2 agonist receptor increases. And the beta-2 receptor, it is also a very, very, very gentlemanly behavior on the part of beta-2 agonists. What it does, it has got some help from steroids, so it also tries to help the steroid receptor. What it does, it comes in and the potency of the anti-inflammatory power of inhaled corticosteroid increases. And so they help each other. So it's a synergistic effect of beta-2 agonist on corticosteroids effect of corticosteroids on beta-2 agonist effect. So they help each other. And so it is rational. So it is absolutely rational. This is, I don't know, can you read it? It's flickering. And beta-2 agonists affect different and complementary aspects of this complex disease pathophysiology. Increased formoterol during exacerbation actually reverses bronchoconstriction, it inhibits mast cell mediator release, and inhibits neutrophil. And the increased budesonide has rapid action and inflammation. I haven't shown you this slide. It decreases the exhaled nitric oxide. This is a surrogate marker which tells me that you are having an asthmatic inflammation and you are going to be bad in a day or two. Eosinophils comes down, mast cell numbers come down, and Th2 lymphocytes are inhibited. So the rescue budesonide formoterol may have enhanced effect, molecular interaction between ICS and LABA, and enhanced anti-inflammatory effect because beta-2 agonist is helping the steroid. So there is a strong scientific rationale for budesonide formoterol smart therapy in asthma because you have a very highly effective maintenance therapy and a very highly effective rescue therapy. So the thing is, we all know that the majority of asthma treatment is done not by guys like yourself, but the general physician, the internist. They have to see from diarrhea to headache to everything. So they can't remember all the names of all the inhalers. They want a simplified treatment. So they want one inhaler. And this is where you get a one inhaler therapy. This actually has been approved by GINA, the Global Initiative for Asthma, and it says combination inhaler containing, this is the important bit. It doesn't matter what steroid you choose, you have to choose formoterol, but Gina has defined as budesonide. This approach has been shown to result in reduction in exacerbation and improvement in asthma control in adults and adolescents at relatively low doses of treatment, and it is evidence A. What we all did all this while is to follow this algorithm. We start with low ICS, inhaled corticosteroids, go up to high inhaled corticosteroids. Then at about step 4, we add LABA, and this is 1% of patients will always be very, very poorly, and it's better for you to, when you send me this patient very severe persistent, I try to refer the patient to my colleague because this is a bad name. No, it's just a joke. But they give a big problem to all the chest physicians. So they comprise of about 1% of asthma population. So what we do now, we add long-acting beta-2 agonists fairly early, very early, step 2, and I'll come to that again. And then this is there all the time. However, we can use a conventional treatment with fluticasone and salmeterol, or a budesonide and formoterol. Whereas if you use smart treatment, I think the days are coming when possibly Gina will approve of treating this step 1, mild episodic asthma with inhaled corticosteroids, or just as and when, because it doesn't matter what we tell our patients, they do not comply. The moment they are better, they stop taking the treatment, and whenever they are slightly unwell, they start taking the treatment again. So it's sort of SOS PRN therapy, and I think it is my understanding that it possibly will work, but no, there is no recommendation as yet. So whatever you choose, BDP with formoterol, or fluticasone formoterol, or mometasone formoterol, or cyclosinide formoterol, we think that they all will work. We do not have the data, all this data, but we think they will all work because of the LABA, the long-acting beta-2 agonist, which is formoterol. And this is a new long-acting beta-2 agonist. Possibly it's coming very soon. It is a once a day long-acting indacaterol, but we understand that this cannot be used as a rescue therapy. But this is where our problem lies. There are about between 1 and 5% of patients suffering from asthma who do not respond to conventional therapy, and there we actually fail these patients. We cannot help these patients, so we resort to new treatment. What are the new treatments available? We have anti-IG. Is it available here? It's phenomenally expensive, omalizumab or Xolair, and it gives benefit to a very, very minority of asthma population. And the problem is we cannot identify that these patients will benefit and these patients won't, and it's phenomenally expensive. The anti-TNF, this has been it's been studied, and there is no reason why we should use it. Actually, it is harmful, so the study was stopped. So, smart therapy will possibly be the most effective therapy for asthma in the next 15 years or so, because that's how long it takes for a new drug to be developed and come to the market, and there is not many new drugs in the pipeline. So that's why I say that smart therapy is possibly the therapy of choice for the next 15 years. Thank you very much.